Question 21.
Yes.
Okay. A previously healthy 8-year-old boy is brought to the emergency department because of fever, abdominal pain, and bloody diarrhea. He he and his family recently immigrated to USA from Mexico. Abdominal examination shows pain and tenderness in the right upper quadrant. There is mild hepatomegaly. Sigmoidoscopy of the mucosal biopsy shows flask-shaped ulcer with healthy intervening mucosa. Which of the following is most likely pathogen?
Ready?
Yes.
So it's an Tamueva histolytica infection with Tamueva histolytica leads to amebiasis, amebitic dysentery. Amebiasis is much more common in developing world. Histolytica is an amoeba parasite and forms cysts which can be transmitted through the fecal oral route and through ingestion of contaminated water. Amoebic cysts mature into trophozoites in the large intestine. Trophozoites may invade the colonic mucosa and interstitium, leading to symptoms of abdominal pain and bloody diarrhea. Invasive infection can lead to colonic perforation and sepsis. If trophozoites enter the bloodstream, they may travel to the liver and cause amoebic abscess, which present with fever and right upper quadrant pain. Diagnosis can be made with the identification of cysts on stool, microscopy, and peripheral smell, which may show trophozoite with endosome containing red blood cell. Trophozoite with endosomes containing red blood cells, as well as by antibody assay and PCR. Colonoscopy shows mucosal ulcers that are often flask-shaped. Treatment requires combination therapy with metronidazole or tinidazole, as well as an antiluminal agent such as paramomycin or idoquinone. Okay, next.
A 2-year-old boy is brought to the emergency department. A 2-year-old boy is brought to the emergency department 30 minutes after he fell approximately 8 feet from the backward porch onto a firm dirt surface. Landing on his back on arrival, he appears mildly uncomfortable. Her temperature is 37 degrees Celsius, pulse is 114 per minute, respiration 28 per minute, blood pressure 85 by 55. Examination shows moderate right-sided flank tenderness. Moderate right-sided flank tenderness. The most appropriate next step in the diagnosis is measurement of which of the following?
Ready? Oh, sorry. Ready? Yes. Sorry. You there?
Yes,
Okay. Ready?
yes.
Oh, it's urine blood. This patient fall from a height and subsequent left flank tenderness raises concern for blunt kidney trauma. Motor vehicle collision, falls, and sport injuries are common causes of this type of injury. A rapid deceleration injury, such as caused by a fall, can cause kidney to be crushed against the paravertebral muscles. A volst from the uteropelvic junction or the renal vessels. Ureteropelvic junctions, the renal vessels, or thrombose. In any of these cases, blood supply to the kidney is interrupted. Flank tenderness, flank bruising, or lower rib fracture should always concern for blunt kidney injury. Hematuria is a common presenting symptom seen in over two-thirds of the patients with blood renal injury. It should be investigated quickly with measurement of urine blood as part of the initial trauma assessment, as IV fluid administration can dilute hematuria and preclude detection. It's not serum creatinine and urea nitrogen are not helpful in diagnosing acute kidney trauma. Near abnormalities in renal function caused by trauma is masked by contralateral functioning kidney. Therefore, neither creatinine nor urea may be used as an indicator of renal trauma. Okay, next.
A 4-month-old girl is admitted to the hospital because of severe coughing for 2 days. A 4-month-old girl is admitted to the hospital because of severe coughing for 2 days. The cough is episodic and staccato-like and often followed by vomiting. The cough is episodic and staccato-like and often followed by vomiting. 1 week ago she developed rhinorrhea. On admission, she appears well when not coughing. Temperature is 37, pulse 120 per minute, respiration 34 per minute. Pulse oximetry on room air shows an oxygen saturation 95%. Examination shows a few petechiae on the face and the thick nasal secretion. And X-ray of the chest shows no abnormality. Which of the following is most likely intervention to prevent nosocomial transmission?
Ready? Ready?
Yes.
So is droplet is isolation. Droplet isolation or droplet precaution in which the eyes, nose, and mouth are covered by glasses and masks would be the most effective way to prevent nosocomial spread of pertussis, an infection characterized by the episode of paroxysmal coughing and post-tussive emesis. Pertussis classically presents in three stages. The catarrhal stage is first, which presents with fever, rhinorrhea, and mild cough. This progresses to paroxysmal stage after 1 to 2 weeks, in which patient experiences violent bouts of extreme coughing at times, violent enough to cause secondary traumatic injuries such as rib fractures, urinary incontinence, pneumothorax, and facial petechiae. Often such coughing, okay. Often such coughing fits are accompanied by cyanosis and may be followed by syncope, emesis, or apnea. The paroxysmal stage can last for 2 weeks, 4 weeks to months. Symptoms resolve during the convalescent stage, which lasts from 1 to 4 weeks. Pertussis can be prevented with immunization in the form of cellular pertussis, typically administered with the tetanus and diphtheria vaccines. DTaP can be given in. It can be transmitted in respiratory droplets. Thus, all individuals who come in contact with infected patients should wear a mask and eye protection. It is not big contact isolation. Is reserved for pathogens such as C. diff, MRSA, and others that are easily transmitted to contact with the skin. These precautions involve wearing uh, by gloves and gowns. Gloves and gowns. Erythromycin therapy for all healthcare workers could be considered in instances of pertussis outbreak, which can occur if the index case is not recognized or droplet precautions are not instituted. Index case not recorded, droplets are not instituted, but is not necessary in this case. Okay.
Next,
Mhm.
a 11-year-old girl spina bifida is brought to the physician because of right thigh pain for 2 days. Right thigh pain for 2 days. She is paraplegic, has limited sensation below the waist. Her temperature is 37 degrees Celsius, pulse 95, respiration 16 per minute. Examination shows of the right swelling of the right breast. কি বললাম? Sorry. Examination shows swelling of the right distal thigh without creases. Sorry, right distal thigh without tenderness. Which of the following is the most appropriate next step in the management?
Don't know. Ready?
Okay.
Okay, so it is X-ray of the lower extremity. This patient presentation with distal thigh swelling is concerning for a fracture of the diaphysis of the femur. Femoral fractures are a common long bone fractures in children with peaks of incidence in toddlers because of accidental trauma and adolescents because of motor vehicle collisions. Femoral shaft fracture may be complicated by shortening of the muscles of the knee and hip, which causes the fracture femur to displace. So early recognition and intervention is needed to prevent permanent limb length discrepancy. Clinically, most femoral shaft fractures will demonstrate obvious deformity, swelling, shortening, or crepitus on exam. Neurovascular exam distal to the site of swelling should be performed to ensure that the fracture has not caused damage to the nerves and arteries. The next step in management of a suspected fracture is radiographic assessment using standard anterior, posterior, lateral plane x-rays of the affected area and the joints above the and below the suspected fractures. This ensures correct diagnosis and assists in management planning. It is not reassurance and application of local heat are not appropriate in this case, as the suspected femoral fracture will need to be immobilized and may require operative intervention. In cases of mild MSK injuries that do not require medical intervention, application of ice is more effective than application of heat. So now, the range of motion exercise may be needed following complete healing of the femoral fracture, but if performed now without adequate treatment, they will likely worsen the fracture. Immobilization is an important step in treatment of femoral fracture. Acetaminophen may be used for mild MSK complaints and is safe for use in children. However, treating pain without addressing the underlying cause, such as fracture, is not appropriate. How did he get a fracture or she got a fracture if she don't walk? She's paraplegic.
Like she's paraplegic. Even if she's paraplegic, she got fractured.
Yeah, like did she fall out of her chair? I guess
Maybe
maybe. Yeah, maybe she fell
it
out.
can
Okay.
happen
Yeah.
while coming down from the bed into the wheelchair. They may fall down because
Yeah.
she's 11-year old, so she can walk, she can run, she can do everything.
Okay.
Okay,
Mm-hmm.
next. A 16-year-old girl is brought to the physician because she has not had a menstrual period. She has not had a menstrual period for 4 months. Menarche was at age 12. Mens previously occurred at regular 30 days interval. She also reports increase she also reports increased hair growth between she also reports increased hair growth between the breast and on her chin, as well as acne on the on her forehead and nose. She has had sexual intercourse for the use condom consistently. She is 163 centimeter tall, 84 kg weight, BMI 32. Physical examination shows hair, coarse hair and chin, coarse hair over the chin and dark velvety skin over the back and the neck. There are numerous papules and pustules over the face. The abdomen is soft, obese, non-tender. There are no masses, breast and pubic hair development causing this patient's symptoms.
Ready?
Yes,
Okay. With ovaries, PCOS presents with irregular menses, infertility, hirsutism, and acne, often in patients with increased body weight. Requires two of the following for diagnosis: an ovulation, PCS on ultrasound, and signs of hyperandrogenism. It is also associated with signs of insulin resistance, such as acanthosis nigricans and increased blood glucose concentration. PCOS is caused by abnormal hypothalamic hormonal feedback response that is caused by primary functional ovarian hyperandrogenism, increased androgen produced by the thicker lutein cells, which leads to increased LH in comparison to FSH. Treatment includes weight loss, combination of OCPs for menstrual regulation, and spironolactone and ketoconazole for hirsutism. Comifen stimulates increased um, ovulation and can also be used for individual desiring pregnancy as can metformin. If the patient is diagnosed with diabetes, oral anti-hyperglycemic medication or insulin may be necessary. It's not hypothalamus. Pathologies can lead to hypogonadotropic hypogamy, which can lead to primary or secondary amenorrhea caused by an ovulation. Hypogonadotropic hypogamy is more common in young athletes, thin female. And it's not pituitary gland. Pathologies can lead to hypogonadotropy, hypogonadism, which again, an ovulation and menstrual irregularities, as well as deficiencies in growth hormone, leading to short stature and prolactin. Okay, next.
ready?
Mm-hmm.
Sorry. An asymptomatic 15-year-old boy is brought to the physician for well child examination. He is concerned because he is the shortest student in his class. Review of the records from the age of 8 years to today shows consistent pattern of height at third percentile and weight at 25 percentile. She has no history of serious illness, no medication. His last routine is 2 years ago. Mm, His mother is 165 centimeter tall. Okay, genital and pubic hair is Tanner stage 2. Remainder of the examination shows no abnormality. Which of the following is the most likely cause of the short stitch?
Ready?
Yes,
Okay. So, yeah. Is constitutional growth delay. This patient most likely diagnosis is constitutional growth delay, which is a normal variant of growth. Short stature has a variety of causes, such as constitutional growth delay, familial short stature, so hereditary, chronic steroid use, endocrine abnormalities such as hypothyroidism, adrenal insufficiency, cardiopulmonary disease, and genetic disorders, Down syndrome, Turner syndrome. Familial short stature and constitutional disorder are the most common cause of short stature. Familial short stature is associated with short stature in both parents. Normal gain of height, velocity, and a born age that corresponds with the chronological age, whereas constitutional constitutional growth delay is independent of parental status, has a consistent decreased growth velocity, and has a born age younger than chronological age. Born age younger. Patients with constitutional growth delay may experience a delayed onset of puberty. These patients typically reach a normal adult height with more rapid increases in height, gain velocity as they progress to puberty. This patient has parents with normal stature and decreased growth velocity, leading to height that is consistently in the third percentile. He does not have other signs or symptoms to suggest pathologic cause or short stature, making constitutional delay the diagnosis. Familial short status typically present in young patients whose parents are both short, with normal growth velocity and bone age consistent with chronological age. These patients will remain of short stature into adulthood. These patient parents have normal stature, making this unlikely. Next.
Okay. A 5-year-old boy is brought to the physician because of clumsiness and frequent falls over 6 months. He did not walk independently until 7 months of age and has always poor motor skill. There is enlargement of the calf muscle and positive coercion. Which of the following is the most likely inheritance pattern?
Oh, Jesus. What was the inheritance pattern? Did X-linked dominance? Oh, no. Ready?
Yes.
Okay. One moment. Okay, so it's X-linked recessive damage. X-linked recessive is the mode of inheritance for Duchenne muscular dystrophy. Children with Duchenne muscular dystrophy typically have an unremarkable birth history, then begin to demonstrate signs of proximal muscle weakness early in childhood. Physical exam discloses difficulty rising from squatting position. Um, yeah, calf hypertrophy and Gowerson using hands to climb up to the lower extremities. Using hands to climb up the lower extremities when rising from the floor. Okay. Proximal muscle include those of the shoulder, grip hip girdles, such as the adductors and flexors of the hip and thigh. Muscle biopsy used to be a mainstay of diagnosis, but genetic tests have rendered this largely unnecessary. Most affected patients will require the use of wheelchair by adolescents. Additional late findings include dilated cardiomyopathy and respiratory failure, which may be the cause of death in this patient. So it's X-linked recessive.
Recessive. Duchenne Baker both are X-linked recessive.
I'm thinking, yeah.
And there is one like classical, like myotonic dystrophy, that may be
Mm,
autosomal dominant.
mm, Let me see. Myotonic. Uh, It says X-linked dominant inherited pattern of scapuloperoneal myopathy, which presents with weakness of the distal leg and scapula. Facial muscle, blah, blah, blah. X-linked dominant the first one mean that, yeah, that one is not myotonic. Oh, no, that one is not myotonic dystrophies. Oh, it says no non-Mendelian pattern is not the correct. Many of the muscular dystrophies are inherited in a Mendelian pattern, although inflammatory and infectious myopathy occurs sporadically and are not generic. Okay, no, it doesn't say the myotonic dystrophy.
But as far I remember, myotonic dystrophy is
Is what?
autosomal dominant.
Autosomal dominant. Okay.
We need to check. We need to find out. Excellent. Mm, okay. Next,
Okay.
a 1 month old a 1 month old boy is brought to the a 1 month old boy is brought for a well child examination. He was born at term he was born at term following an uncomplicated pregnancy. 15 months after delivery, a very soft systolic murmur was heard along the left sternal border. Along the left sternal border, he appears well today. Temperature is 37 degrees. Pulse 140 per minute. Respiration 28 per minute. Blood pressure 76 by 54 millimeter of mercury. He is at 50 percentile. He is at 50 percentile for length and weight. A grade 3 by 6 holosystolic murmur is heard best at the middle left sternal border. Examination shows no abnormality. Which of the following is the most likely physiologic mechanism for the change in the intensity of the patient's murmur? Left sternal border.
Hmm. Second, sorry.
What is the diagnosis?
I don't know. I'm not even going to try to figure out the diagnosis in this one. Increased
Very
circulation.
murmur heard at the left sternal border. In the left sternal border, the murmurs are a VSD.
It says BSD is the lower left. Upper left is ASD and the P ones, pulmonic ones. Um, so would that be like pulmonic, holosystolic? They cannot be pulmonic. Holosystolic. All physicians take. Maybe tricuspid. If it's tricuspid,
There
then
is
it says middle left sternum. So it's VSD. Oh, and it's probably not this. It's this one. Never. I cannot remove this. Oh no, it's not going now. Never mind. Okay. Ready?
yes.
It's probably E. Nope, it's not. Decreased pulmonary vascular resistance. Decreased pulmonary vascular resistance most likely explains the increased intensity of this patient holosystolic murmur, which is consistent with VSD. Oh, right. Normal fetal circulation is unique. Normal fetal circulation is unique in that oxygenated blood arrives from the maternal circulation via the umbilical vein. and reaches the IVC. From there, oxygenated blood is shunted from the right atrium to the left atrium, left ventricle, and systemic circulation. The fetal lungs are filled with amniotic fluid in utero, so the pulmonary vascular resistance is high.
Yes, myotonic dystrophy is autosomal dominant.
Is autosomal. Okay, got it. In patients with VSD, increase increase pulmonary vascular resistance effectively prevents left to right shunting. Okay. Of blood from the left ventricle to the right ventricle. Increase pulmonary vascular resistance. At birth, amniotic fluid is clear and expelled from the lungs, and the pulmonary vascular resistance uh, falls. Falls, followed by gradual decrease in PVR over the next several weeks. As the PVR decreases, the pressure gradient between the left and right ventricle increases, such that the blood is shunted from the left ventricle to the right ventricle with each cardiac cycle. This change in PVR explains the change in the patient's murmur. Primary vascular resistance explains the change in patient. That doesn't make sense to me. Okay, it's not improve MI. Oh,
I don't
improve.
understand the explanation
I
actually.
don't understand the explanation too. They are saying that
Can you
because
read the
the
educational objective?
okay in the fetal circulation, increased PVR pulmonary vascular resistance prevents left to right shunt from the left ventricle to the right ventricle to the through the VST. At the time of birth, the rapid decrease in PVR creates a substantial pressure gradient between the two ventricles and allows for the development of left to right shunt. The PVR continues to drop off the following weeks and likely accounts for the change in this patient murmur. Okay.
Okay, what they are looking for. Like,
Fine.
huh, okay, next.
Oh, I was going to read. Improved
Yes.
myocardial contractility will not explain the change in the murmur. As increased contractility will likely be equal between two ventricles, with little to no change in the pressure gradient between the two. Increased circulating blood volume is incorrect. VSDs that are large enough to cause right ventricular overload may manifest later in life with evidence of right heart failure and volume overload. I still don't get what they're saying. Okay, next.
A 3-year-old boy is brought to the physician. A 3-year-old boy is brought to the physician because of eye swelling for a week. His blood pressure is 120 by 60. Examination shows generalized edema and ascites. Generalized edema and ascites. 3-year-old boy. Okay, serum studies show a creatinine zero point 0.4, albumin 1.4, cholesterol 569 milligram per deciliter. Urinalysis shows 4 plus protein and do not blood. So nephrotic syndrome. Which of the following is the most likely diagnosis? Uh, Ready?
Yes, it is the right place here. Minimal change nephrotic syndrome. Nephrotic syndrome is characterized by edema secondary to excessive proteinuria resulting in hypoalbuminemia and diminished intravascular oncotic pressure. Intravascular oncotic pressure, yeah. This occurs because of loss of normal site in charge filtration capability of the glomerular capillary and pulmonary capsule interface. Causes of nephrotic syndrome include minimal change disease, membranous nephropathy, and FSGS. Minimal change disease is the most common cause of symptom. Nephrotic syndrome in children and can be idiopathic or triggered by recent infection or immune stimulus. Patients classically present with dependent edema in the buttocks, lower back, legs, foamy and dark color urine, hyperbilinemia, and proteinuria. Complications include hypercoagulability caused by urinary loss of antithrombin 3 and infection caused by urinary loss of globulins. The loss of protein and decreased serum oncotic pressure in nephrotic syndrome leads to hepatic protein synthesis, especially lipoproteins, which cause hyperlipidemia. It is not FSGS. I want to know. FSGS is a nephrotic syndrome that can result in proteinuria and pitting edema. However, FSGS is commonly associated with sickle cell disease, opioid abuse, and HIV and is characterized by segmental sclerosis of the glomerula. Okay.
Okay,
Yeah.
next. A 2-year-old girl, a 2-year-old girl sickle cell hemoglobinopathy has a 2-week history of paroxysmal cough followed by vomiting. Lab studies show leukocyte count is 32,000. Lab studies show leukocyte count is 32,000. Lymphocyte is 85%. Segmented neutrophil 10%, monocyte 5%, which of X-ray of the chest show perihilar lymph perihilar infiltrate. Which of the following vaccine could have prevented this condition?
Perihilar infiltrate. It has a viral, viral, paroxysmal cough and vomiting. Oh, the fuck? Why am I wasting too much time? Okay, ready?
Yes.
Okay. It's diphtheria, DTaP. Episodes of severe paroxysmal coughing are concerning for pertussis. Pertussis occurs because of an infection from Bordetella pertussis. Um, and classically presents with three stages. The catarrh stage first presents with fever, rhinorrhea, mild cough. This progresses to the paroxysmal stage after 1 or 2 weeks, in which patients experience bouts of extreme coughing, at times violent enough to cause secondary traumatic injury like rib fractures, urinary incontinence, and pneumothorax. Often such coughing fits are accompanied by cyanosis and may be followed by syncope, emesis, or apnea. The paroxysmal stage can last from weeks to months. Symptoms resolve during the convalescent stage, which lasts from 1 to 4 weeks. Pertussis toxin causes impaired recruitment and migration of phagocytes. Impaired recruitment and migration of phagocytes. Um, and production of inflammatory mediators. Patients often have significant lymphocytosis. Pertussis can be prevented with immunization in the form of the cellular pertussis typically administered around tetanus and diphtheria vaccines. The CDC recommends administering the vaccine in a multiple dose series beginning at 2 months. Pertussis is treated with antibiotics, typically macrolides, and supportive care. Okay.
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 Okay. Let's take a break for 5 to 10 minutes.
Okay.
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 Okay. A 5-month-old girl is brought to the physician because of a daily episodes of vomiting after feeding. Her mother reports that her mother reports that the episodes began shortly after The episodes begin shortly after birth, and that the vomiting is occasionally bilious. So bilious vomiting after feeding. Her diet consists of soya-based formula. Trials of multiple infant formula have not stopped the vomiting. Abdominal examination shows no distension or tenderness. There are no masses. Normal bowel sounds are heard. Upper GI series is shown. Which of the following is the most likely diagnosis? Well, ready?
Marutation. Yep. Yep. Okay. So it's intestinal malrotation. Intestinal malrotation is a congenital anomaly in which the midgut incompletely rotates during development. This leaves the midgut attached to a thin stalk or mesentery of at the base of the superior mesenteric artery instead of normally broad-based mesenteric stalk. The cecum also remains in the abnormal position within the mid-upper abdomen instead of the right lower quadrant and is attached to the lateral abdominal wall by fibrous band, which cross over the top of the duodenum and can also cause constriction. This leaves the small intestine iris for volvulus, originating at the base of the SMA. While most patients present in their first year of life, some individuals do not present until later childhood or adulthood. Mm. In this case, the patient upper GI barium series demonstrates the presence of small intestine only within the right abdomen. In its usual anatomic position, the duodenum crosses the midline toward the ligament of Thwaites, and the remaining small intestine courses throughout the abdominal quadrants. Thus, the imaging findings suggest malrotation of the small intestine. Okay, so it's only here. Okay. Malrotation of the intestine predisposes to intestinal obstruction. In this case, the persistent vomiting of bilious emesis suggests a partial small bowel obstruction secondary to patient's malrotation. Cyclic vomiting syndrome is an idiopathic disorder seen in both children and adults characterized by recurrent episodes of vomiting with periods of normal health in between. In this case, the bilious nature of the vomiting suggests that it is attributable to a structural cause instead. GERD is caused by acid reflux into the lower esophagus. This commonly occurs as a result of increased intra-abdominal pressure or diminished closing pressure of the lower esophageal sphincter, permitting acid contents of the stomach to reflux into the esophagus. In infant, the GERD disease presents with frequent regurgitation without excessive irritability. Bilious vomiting is a warning sign of structural cause of vomiting rather than GERD. Hiatal hernia is caused by defect in the diaphragm of the esophageal hiatus that allows for lower esophageal sphincter and variable amounts of the stomach to be displaced into the thorax. It can cause heartburn, nausea, emesis, dysphagia, regurgitation, and shortness of breath. Does not cause bilious emesis or the, yeah, next.
A 13-year-old boy, sorry, the 13-year-old girl is brought to the physician because of two week history of mild neck tenderness. She has not had fever, fatigue, sensitivity to hot or cold, or changes in weight. He has no history of serious illness. Takes no medication. Her mother has SLE. The patient is 50% for height and weight. Pulse is 88 per minute, respiration 18 per minute, blood pressure 112 by 72. Examination shows normal skin texture. There is no exophthalmos. The skin is supple. There is no lymphadenopathy. The thyroid gland is diffusely enlarged. No nodules are palpated. Serum studies show TSH 3.9, T4 10, and T3 is 135. This patient's anti-TPO antibody is 1000 international. Normal is less than 20. Which of the following is the most likely diagnosis?
Maybe.
Isn't it T4 is high?
No, they are all normal.
Okay,
I mean,
everything is normal.
based on the, yeah, they are all normal.
Okay,
Okay, so is Hashimoto thyroiditis. Chronic lymphocytic Hashimoto thyroiditis is the most common form of thyroiditis and is characterized by the presence of antithyroid peroxidase, antithyroid peroxidase and antithyroglobulin antibodies. Female patients are disproportionately affected, are more affected than males. The early stage of Hashimoto can present with neck swelling and diffusely enlarged non-tender thyroid gland. The patient may display evidence of hyperthyroidism from destruction of thyroid follicular cells and the unregulated release of thyroid hormone. During the chronic stages of Hashimoto thyroiditis, the patient typically develops primary hypothyroidism um, from the underlying inflammatory destruction of normal thyroid parenchyma and resultant insufficient production of thyroid hormone. Signs and symptoms during this stage include fatigue, cold intolerance, weight gain, hyporeflexia, myxedema, dry, cool skin. By needle biopsy demonstrates lymphoid infiltrate with the presence of follicles and Hurtol cells. Treatment is with oral replacement of thyroid hormone. Yeah.
okay.
Mhm.
A 14-year-old boy with a cardiac murmur is brought to the physician for school for physical examination. He reports that during this uh, during this past soccer season, he easily become short of breath at time, but did not seek medical attention. He has no symptoms of chest pain, palpitations, syncope. He appears healthy. His pulse is 72 per minute, respiration 18 per minute, blood pressure 126 by 42 millimeter of mercury. Cardiac examination shows a blowing diastolic murmur at the upper sternal border. Can you give me a moment? I am coming. 1 minute. You
Sure.
you keep in the call. Okay. Hello? Yes. Are you there? Hello? Are you there? Okay.
Okay.
If
Radio
question
perception.
33.
33. Yes.
Okay. I will read it again. Okay. A 14-year-old boy, a 14-year-old boy with a cardiac murmur is 14-year-old boy with a cardiac murmur is brought to the physician for a school physical examination. He reports that during this past soccer season, he easily became short of breath at times but did not seek medical attention. He has no medical He has no symptoms of chest pain, palpitation, syncope. He appears healthy. His pulse is 72 per minute, respiration 18 per minute, blood pressure 126 by 42 millimeter of mercury. Cardiac examination shows a blowing systolic murmur in the upper right sternal border. There is no systolic murmur. Radial and pedal pulses are 3 plus bilateral. Which of the following is the most likely cause?
Ready? Ready?
Ready?
Yeah. Okay. So is left ventricular volume overload? Left ventricular volume overload as a result of aortic insufficiency explains this patient-wide pulse pressure, mhm, blowing diastolic murmur, and bounding radial pulses, in addition to exertional symptoms. The causes of aortic insufficiency or aortic regurg are called include bicuspid aortic valve, aortic root dilation, and history of rheumatic heart disease. It is also commonly associated with syndromes such as Marfan and Turner syndrome. Aortic AR results from incompetent aortic valve that allows retrograde blood flow from the aortic root to the left ventricle during diastole. This results in an increased left ventricular and diastolic volume, as both blood from the aorta and the left atrium fill the left ventricle. Increased volume stretches the compliant ventricle, thereby increasing myocardial contractility, which is reflected as an increase in stroke volume and a comparatively increased cardiac output. Um, Over time, eccentric hypertrophy of the left ventricle lead to loss of normal compliance and progressive left systolic dysfunction. It is not B. Increased systemic cardiac output is incorrect. In compensated AI, the cardiac output is maintained, but over time, the progressive hypertrophy of the left ventricle in combination with ongoing aortic regurg leads to systolic dysfunction and decreased cardiac output. Is not increased systemic vascular resistance is incorrect. SVR tends to be relatively normal in individuals with AR, with chronic compensated AR, although they tend to have disparity between greater disparity between systolic and diastolic pressures. The large volume ejected during systolic transiently increases the systolic pressure. Um, while the regurgitant volume back into the left ventricle leads to a lower than expected diastole. Left ventricular pressure overload is incorrect. In young patients with chronic AI and no evidence of heart failure, the left ventricle is able to compensate for increase in diastolic volume by distending, thereby maintaining a normal left ventricular and diastolic pressure over time. However, eccentric hypertrophy can cause diastolic dysfunction and increase left ventricular pressure. Okay. Next.
How you diagnose this as aortic insufficiency?
It's on the right. The only one that's on the right of the sternal is aortic. Remember the mnemonic all physicians take money?
Yes.
Yeah, so the only one on the right is aorta. And then diastolic, it cannot be aortic. What's the other one? Aortic stenosis, because aortic stenosis will cause a systolic murmur. So it can only be aortic regurg.
Okay.
Yeah.
A 15-month-old boy is brought to the physician for an initial examination. According to his mother and previous medical records, he has been healthy and developmental milestones are appropriate for age. At his last examination 3 months ago, he was at 25 percentile for length and the weight. Today he is at 25 percentile for length, 25 percentile for length and 10 percentile for weight. She has no abnormalities. Which of the following is the most appropriate step in the evaluation of his poor weight gain?
Okay.
Okay.
Recommend a diary with calorie counts. This chart demonstrates a decreased velocity of weight gain compared to his clothing line, raising the concern for a diagnosis of poor weight gain and malnutrition. Poor weight gain is a common diagnosis seen in primary care offices in approximately 5% of pediatric patients. Risk factors include prematurity, developmental delay, congenital abnormalities, or any condition resulting inadequate intake, absorption, or metabolism of nutrients. Poverty, social isolation, certain nutritional beliefs and practices, poor parenting skills, substance abuse, violence, and other abuse also predispose to poor weight gain. The first step in evaluation of poor weight gain is to take a throughout um, or throughout, I don't know, history of dietary practices and review systems. If not suspected underlying organic cause is found, management of mild malnutrition should involve parental education and dietary advice. Changes to dietary practices, provision of home-based support, and referral to community or governmental programs to increase access to food. Recommending a diary with calorie counts will both investigate whether inadequate caloric intake is the cause of the childhood weight and also assist caregivers in creating a personalized feeding plan. It is not, see, tests for reducing substances and fecal fat may be performed in children whose poor weight gain has not resolved with appropriate diet intervention to investigate malabsorption as a potential cause. It's not warranted prior to attempting diet intervention. In an otherwise asymptomatic child, obtain X-ray of the abdomen is not necessary in this case, as the patient has no symptoms such as vomiting, abdominal pain, decreased appetite, diarrhea, suggestive of an abdominal pathology. Okay, next.
Yes. A 10-year-old girl A 10-year-old girl is brought to the physician because of swelling of the eyelid and feet for 3 days. Over the past week, she has had decreased urinary frequency. 2 weeks ago, she had a sore throat that resolved spontaneously. Her temperature is 37.3 degrees Celsius. Pulse is 100 per minute, respiration 18 per minute, blood pressure is 140 by 85. Examination show periorbital, pretibial, and pretibial and pedal edema. Immunoanalysis show pH 6, specific gravity 1.015, protein 3 plus, blood large protein 3 plus RBC 2 numerous count, WBC and WBC is 5 to 10 high power field and RBC cast is present and 10 to 20 high power field. Which of the following is most likely cause of this patient's hypertension?
What causes hypertension in nephritic syndrome? Is hmm, it the mineralocorticoids? I don't know. I don't know. Anyway, ready?
Okay.
It is volume overload. Acute PSGN is a type of nephritic syndrome characterized by dark color urine, hypertension, acute kidney injury, hematuria, and proteinuria, following an infection with strep pyogenes. Soft tooth. Glomerular injury in PSGN involves immune complex formation in the glomerulus, and light microscopy shows deposit of C3 and IgG in the glomerulus and mesangium. A urinalysis shows hematuria and variable proteinuria with or without red blood cells, CAS. Hypertension associated with PSGN is caused by salt and fluid retention, resulting in volume overload. Fluid retention can lead to edema, include periorbital, pretibial, pedal edema, can also lead to complications involving heart failure, pulmonary edema, and respiratory distress. It's not catecholamine excess can occur in pheochromocytoma, which presents with episodic headache, sweating, palpitation, tremor, agitation, tachycardia, arrhythmia, and treatment-refractory hypertension. This is the most common primary tumor of the adrenal medulla and is marked by functional secretion of epinephrine or epinephrine dopamine. Mineralocorticoid excess can occur in hyperaldosteronism, an increased secretion of aldosterone from the adrenal gland. This can be seen with adrenal adenoma or hyperplasia and presents with hypertension, normal or decreased potassium concentration, metabolic alkalosis. It will not present with hematuria and proteinuria.
Okay.
So the what causes the what causes the volume overload in PSGN? Why is there volume overload? You know the mechanism?
No.
No. Okay.
You can search it in the Gemini.
Mm. Okay. Oh, let me search it. Can I search it now since I'm already? What causes volume overload in nephritic syndrome? I guess in PSGN. Is direct consequence of kidneys' imperability to filter blood and excrete excess fluid and sodium. Okay.
So there are some hypotheses also. Decreased GFR, increased sodium excretion, and
Where is it?
primary
Where,
salt retention.
where are you reading it? Is it like the one I'm showing, or you're reading another thing?
I'm reading, my explanation is different. I wrote volume overload in nephritic syndrome.
Mm-hmm. What does it say?
So they told the pathophysiology of the volume overload in nephritic syndrome. First
Mm-hmm.
one is glomerular inflammation and dysfunction, which causes decreased GFR, impaired sodium excretion. Decreased GFR, uh, this inflammation reduces the efficiency of the filtration, leading to decreased urine output, that is oliguria, and impaired sodium excretion, and there are maybe primary salt retention, and there may be fluid accumulation and edema. Mm,
Okay, got it. So it messes up the kidney, so the kidney cannot filter the blood, and yeah,
yes,
the
maybe
problem there.
glomerular damage and glomerular filtration problem.
Got it. Next.
Okay, a 3-day-old girl, a 3-day-old girl with Down syndrome has not had a bowel movement, has not had a bowel movement since birth. She feeds poorly but has not vomited. She has not had any other symptoms. She was born at term, a 39-year-old primary gravid woman following an uncomplicated pregnancy and spontaneous vaginal delivery. Rupture of the membrane occurred 6 hours prior to the delivery. There is no meconium. Staining of fluid. Apgar score shows 6 and 9 in 1 to 5 minutes respectively. The patient's temperature is 100 degree Fahrenheit. Pulse is 140 per minute. Respiration 40 per minute. Blood pressure 90 by 55. Examination show epicanthal fold, white stellate spot on the irids, single palmar creases, and white spaces between first and the second grade toe. The abdomen is soft and non-tender. There is no organomegaly. Muscle tone is decreased in the trunk. Which of the following is the most likely explanation for this patient failure to pass the stool?
Ready?
Ready?
Mm-hmm. So it is absence of ganglion cells in the bowel. Congenital megacolon, congenital megacolon, also known as Hirschsprung disease or intestinal agangliosis. No ganglion, congenital megacolon. It's caused by congenital absence of the distal portion of the mesenteric plexus, a part of the enteric nervous system located between the inner and outer layers of the muscularis externa and in the bowel wall. During development, these plexus migrate cephalad to caudal, so head to butt. An incomplete migration results in absence of the plexus in the distal portion of the GIT. This often leads to inability to pass meconium within the first few days of life and eventually large bowel obstruction. An explosive expulsion of feces on rectal exam is a common clinical finding. Bariomenema is used to evaluate for congenital megacolon in children. Congenital megacolon is associated with Down syndrome. Patients with Down syndrome also have increased risk of Alzheimer's, ALL, AML, cardiac septal defect, and duodenal atresia. Okay, next.
A 3-year-old boy is brought to the physician because of increasing lethargy and jaundice over past week. At birth, he had jaundice treated with phototherapy for 5 days. He had splenectomy at the age of 6 years. His father has splenectomy at the age of 6 years. Developmental milestones and diet are normal for age. Examination shows mild scleral icterus, a grade 2 by 6 systolic ejection. A grade 2 by 6 systolic ejection murmur is heard. The splenic tip is palpated below palpated 4 cm below the left costal margin. Lab studies shows hemoglobin 8.3, leukocyte count 6,500, segmented neutrophil is 40%, lymphocyte 55%, monocyte 5%, reticulocyte 10%, serum total bilirubin 5 mg per deciliter. Direct and indirect antiglobulin Coombs test are negative. Blood smear show which of the following type.
Hypochromic. Ready?
Is it sickle cell disease?
I'm thinking, right? Because the dad and the splenectomy or not. And sickle cells is it's not microcytic. It's not macrocytic. It must be normocytic. But I don't remember if it's hypochromic. Probably not. I don't know.
Okay.
Okay, so it's normocytic, normochromic. Normocytic, normochromic is the correct answer. This patient with evidence of hemolytic anemia, increased reticulocyte count, family history of similar symptoms, requiring splenectomy, likely has, oh, never mind, hereditary stereocytosis. Hereditary prostatitis can occur if there are mutations in one or more proteins that link the erythrocyte in a membrane skeleton to the outer lipid layer and include mutation in spectrin, arginine, and band 3 and band 4.2. These mutations are inherited in an autosomal dominant pattern. Spherocytosis results from progressive loss of erythrocyte membrane over time and gives the erythrocyte a spherical shape. The surface area decreases, but the volume of the cell remains unchanged. This impairs the erythrocyte ability to confirm in small vesicle, to confirm in small vessels of the microcirculation, especially within the spleen, where spherocytes accumulate. Patients often present with splenomegaly, hemolytic anemia, and pigmented gallstones. Peripheral smear will show normocytic normochromic erythrocytes, and if there is a high degree of hemolysis, reticulocytes will be uh, uh, reticulocytes, which appear as larger pale blue erythrocytes. Definitive management involves splenectomy. I mean, we didn't get the diagnosis right, but we got the answer right.
Yes.
Yeah. Mm, next.
A 1 day old newborn is jittery and irritable. He was born at term. 25-year-old primary gravid woman. 25-year-old primary gravid woman who received irregular prenatal care. Maternal serology screening on admission was negative for hepatitis B, rubella, HIV, syphilis. The newborn weight is 4.7 kg. The anterior frontal alley is 1.5. Posterior frontal alley is barely patent. The lungs are clear to auscultation. Cardiac examination shows regular rate and rhythm with a 2 by 6 hollow systolic murmur through the precordium and strong femoral pulses bilaterally. The abdomen is soft. Without masses or episplenomegaly. Genital examination shows no abnormality. Neurological examination show slight jitteriness and but normal tone. Which of the following is the most likely cause of this species? Newborn neurologic finding.
Jittery. Mm. Ready?
Okay.
Okay. So is hypoglycemia. Excessive fetal exposure to insulin in utero can cause macrosomia, NRDS, or hyaline membrane disease, and hypoglycemia in the newborn. HPL, human placenta lactate, produced by the placenta, increases maternal insulin resistance. It leads to increased concentration of glucose in maternal circulation and subsequently the fetal circulation. Fetal hyperglycemia in turn causes the fetus to produce excess insulin and decreased rate of gluconeogenesis. The insulin then acts as a growth factor, leading to macrosomia, and it inhibits the production of surfactant, which can lead to NRDS. After birth, the newborn continues to synthesize insulin, but is no longer exposed to high blood glucose, which leads to hypoglycemia. Hypoglycemia presents in the newborn with tremors, diaphoresis, irritability, lethargy, and seizures. Treatment is supported and includes administration of glucose while neonatal endocrine regulation self-corrects. Maternal diabetes, which is usually diagnosed by routine glucose tolerance at 24 to 28, which can also cause other neonatal complications, including congenital cardiac and neurologic abnormalities like PDA, VSD, cardiac regression, preterm delivery, polycythemia, and hyperbilirubinemia. It is not B. Hypermagnesemia in infants can be caused by magnesium sulfate administration in the mother in preeclampsia or eclampsia. It causes hypotonia, respiratory depression in the newborn, but does not cause jitteriness. Hypocalcemia presents with jitteriness, myoclonus, and seizure, as well as occasional laryngospasm and bronchospasm. It is commonly associated with the George, which causes paratoid apoplasia and severe hypocalcemia. However, the George syndrome is associated with craniofacial abnormalities that this patient does not exhibit. Okay.
Okay, next. 20, 20 12 hours after undergoing circumcision. 12 hours after undergoing circumcision, a 3-day-old boy persistent bleeding at the circumcision site. He was born at 38 weeks of gestation to a 23-year-old primary gamet woman following an uncomplicated pregnancy and delivery. He was given an intramuscular injection of vitamin K immediately after delivery. His temperature is 37.5, 99.5 degrees Celsius Fahrenheit, pulse 140 per minute, respiration 55 per minute, blood pressure 60 by 40. Examination shows prominent right parietal cephal hematoma. There is ecchymosis. There is an ecchymosis at a vitamin K injection. There is an ecchymosis of the vitamin K injection and continuous oozing of blood at the circumcision site. Hematocrit 53%, leukocyte count 10,500, segmented neutrophil 50%, basophil 4%, lymphocyte 40%, monocyte 6%, platelet count 3 lakh 50,000, PT 12, PTT 90. Which of the following is the most likely cause? Okay,
One moment. Mm, subseasonal. 8. They gave him vitamin injection. Platelet dysfunction, maybe. Table tennis
In
is
vitamin K deficiency, PT, PTT both will be low. Oh, sorry, PT low or high?
high.
High.
Platelet dysfunction is 6, 7, 6, 7, 8. So it will be PTT that will have an issue. Hmm.
Is it like
Seven,
bleeding?
eight, 2, 7, 9, 2, 7, 8. Yeah. Okay. Ready? You say, oh, sorry.
Yes.
You said you already. Um, so is what's that one? Factor 8 deficiency. Factor A deficiency results in hemophilia 8. Is the most likely diagnosis in this patient with uncontrolled bleeding for syncytial size, large right cephalohematoma in abdominal PTT, play table tennis inside PTT, normal PT and normal platelet count. Hemophilia A, X-linked recessive condition and is therefore more commonly seen in male, while most females are silent carriers. It's caused by absence of or deficiency of factor 8, which is a component of the intrinsic clothing cascade. Factor 8 is required as a cofactor for the activation of factor 10 and 10A, which in turn converts prothrombin to thrombin to complete the process of clot. PTT measures the activity of the intrinsic pathway and will be prolonged in cases of hemophilia A, while the PT measures the activity of factor 7 extrinsic pathway, which is normal in this patient. Platelet dysfunction can be inherited or acquired and can also result in prolonged bleeding, but PTT is usually normal, makes sense. While bleeding time will be increased. Examples of inherited platelet disorders, Glassman thrombasthenia, Wiskov, Aldrich syndrome, and platelet granule disorders. Okay, next.
Yes.
Mhm.
40, sorry,
I'm sorry.
4 hours after 4 hours after an elective cesarean delivery at 38 weeks of gestation, a newborn has nasal flaring and tachypnea. There was no staining of the amniotic fluid. The mother received regular prenatal care. She has no fever or illness during the pregnancy. She has no fever and illness during the pregnancy. The newborn's temperature is 37.6 degrees Celsius. Pulse is 180 per minute. Respiration 80 per minute. Pulse oximeter on room air shows oxygen saturation 88%. The lungs are clear to auscultation and X-ray chest show prominent vascular markings. Fluid lines in the fissure, and flat diaphragm. Which of the following is the most likely diagnosis of this patient?
Mm-mm.
Is it the specific one like fluid line in the fissure?
I think so, but I don't know why it has a flat diaphragm, but yeah, sounds like that one.
Okay, ready?
Okay, yep. So it's transient tachypnea of the newborn. Transient tachypnea of the newborn presents within a few hours of birth. With tachypnea, respiration is greater than 60 and signs of respiratory distress such as cyanosis, nasal flaring, and intercostal and subcostal retraction. It is caused by the delay in the resorption of fetal amniotic fluid in the alveoli. The residual fluid in the lung decreases the pulmonary compliance, which leads to an increased work of breathing, tachypnea, hypoxia in the newborn, and to air trapping through relative compression of the bronchioles. Auscultation of the chest is typically normal. Chest X-ray will show flat diaphragm and pulmonary congestion with fluid in the interlobulus fissures, as well as occasional pleural effusion. Risk factors for its development include preterm birth, diabetes in the mom, C-section, maternal asthma. Treatment is typically supportive with supplemental oxygen as needed, with the majority of cases resolving between 1 or 2 days. It is not EF. Pulmonary hemorrhage typically presents with dyspnea, hypoxia, tachycardia, profound hemoptysis, which may be life-threatening. In children, it can occur with foreign body aspiration, trauma, and bronchiectasis, as well as rheumatologic and hematologic disorders. This patient has no report of hemoptysis. Respiratory distress syndrome of the newborn occurs in preterm infants because of surfactant deficiency. That leads to alveolar collapse. This leads to increased work of breathing, hypoxemia, and cyanosis, typically apparent at birth and can be differentiated from transient acute on the newborn with a chest survey that shows bilateral gland of okay, that makes sense. Why is said the flat diaphragm on transient acute of the newborn? You know,
No,
diaphragm, diaphragm in transient tachypnea of the newborn. Hyperinflation of the lungs. Okay.
decreased clearance of lung fluid.
Mm, okay. Next.
Okay. A 3.7 kg newborn is delivered 43 weeks of gestation to a 32-year-old woman, gravida 4, para 3, Apgar score 3 and 5 in 1 to 5 minutes respectively. The newborn skin and nails are meconium stained. A cyanotic A is immediately intubated and mechanically ventilated at FiO2 of 100%. No meconium is noted below the vocal cords prior to the insertion of the endotracheal tube. 1 hour later, he remains cyanotic. The lungs are clear to auscultation. Umbilical arterial blood gas catheter pH is 7.1, PCO2 is 34, and PO2 is 26. So, acidosis, respiratory acidosis, isn't it? Sorry, metabolic acidosis or
This,
respiratory.
this
Okay,
is normal. PCO2 is normal and O2 is low.
O2 is low, but pH is very low. Okay,
Mhm.
and extra chest show cardiomegaly, echocardiography show normal cardiac anatomy right to left sham through a foramen oval. Which of the following is the most likely mechanism?
The most of these findings. Mm, mm, increased peripheral vascular resistance, intracardiac, left to right shunt. I don't know. Closure of the ductus arteriosus. I'm confused by this question. Ready?
Yes.
It is failure of pulmonary vasodilation. Oh. Failure of pulmonary vasodilation resulting in significant pulmonary hypertension is the most likely cause of this patient right to left shunt across the foramen ovale and persistent hypoxemia. Normal fetal circulation is unique in that the oxygenated blood arrives through the maternal circulation via the umbilical vein and reaches the IVC directly. From there, mm, oxygenated blood is shunted from right atrium to left atrium to the left ventricle and then to the systemic circulation. Oxygenated blood that reaches the right ventricle and the pulmonary arteries is shunted through the ductus arteriosus to the aortic arch. Okay. Before birth, the fetal lungs are filled with amniotic fluid, and the pulmonary PVR, primary vascular resistance, is high. Under normal circumstances, the first breath leads to decrease in PVR as pulmonary vessels dilate. Peripartum asphyxia, as in this case, in addition to acidosis, impairs the normal transition from an increase to decreased PVR state. Despite adequate delivery of oxygen after intubation, persistently increased PVR impairs oxygenation. As such, pulmonary hypertension most likely explains this patient's persistent hypoxemia. Mechanical aspiration also causes big ventilation perfusion mismatch, it is the result of obstructed bronchial tree with normal perfusion. Mm. So it's not closure of the ductus arteriosus, which is a shunt between the pulmonary arteries and aortic arch, typically occurs within several days after birth. Failure to closure results in an extracardiac left to right shunt and classically presents with continuous machine-like movement left to right. So wouldn't cause hypoxemia. Okay, next.
A previously healthy 7-year-old girl is brought to the physician by her father because of 4-month history episodes of bright red blood in her stool. Are not associated with the episodes are not associated with pain, constipation, diarrhea. Growth and development are appropriate for age. Temperature is 37 degrees Celsius plus 90 per minute. Respiration 18 per minute. Blood pressure 110/65. Examination of the face shows an area of the hyperpigmentation of the lips and the buccal mucosa. A photograph is mouth is shown. Examination of the anus shows no feature. Examination of the anus show no fissures or signs of the trauma. Digital rectal examination shows bright red blood. Which of the following is the most appropriate next step? Okay.
Okay. So it is colonoscopy. Um, Peutz-Jeghers syndrome is a genetic condition inherited in autosomal dominant fashion. It's characterized by the triad of colonic polyps, mucocutaneous hyperpigmented macules, and increase for GI and non-GI malignancies. In this syndrome, hematomatous polyps are scattered through the GIT and are associated with increased risk for colorectal and gastric cancer. Acute bleeding episodes from one of those polyps leading to bright red blood in the stool, as in this case, are common. The bleeding may also be occult and cause iron deficiency anemia before it's recognized. Yearly complete blood count to screen for anemia is recommended. Baseline endoscopic evaluation utilizing both upper endoscopy and upper and colonoscopy is recommended to evaluate for malignancy. Blue-gray pigmented macules are started primarily in the perioral region and the lips. They may be confused for freckles, but are caused by increased numbers of dermal macrophages containing melanin rather than increased height of melanosome. The blue-gray cutaneous macules in PG syndrome are not malignant. It's not. Should I read? Yeah. Stock culture is an appropriate next step in the workup of bloody diarrhea, thought, thought to be caused by bacterial infections such as E. coli and Shigella. However, this patient has had blood in her stools for the past 4 months. She also has no fever or signs of infection. Upper GI series will not be useful in evaluating colon polyps. Direct visualization of the colon via colonoscopy is better suited for polyps. Furthermore, if a source of bleeding is identified on colonoscopy, intervention can be made to stop it. Okay, next.
Okay. Hello.
Yeah.
Okay, next. A 16-year-old girl is brought to the a 16-year-old girl is brought to the emergency department by friends after a pass after she passed out of a party. After she passed out of a party, she has a history of substance abuse there, and saw that she drank more than 8 glasses of alcohol during the past 2 hours. On arrival, she does not respond to painful stimuli. Her temperature is 100 degrees Fahrenheit, pulse is 110 per minute, respiration is 61 per minute and shallow. Blood pressure is 110 by 70. Pulse oximetry on the room mirror shows an oxygen saturation is 90%. Examination shows scleral icterus. The liver age is palpated 1 centimeter below the right coastal margin. Which of the following is the most appropriate next step in the management?
No, system dialysis and the tracheal intubation. Ready?
Okay,
Hmm. So it is endotracheal intubation. Then the patient presents after drinking a large amount of alcohol with altered mental status, obtundation, respiratory distress, and hypoxia. The patient also has signs of chronic excessive alcohol abuse, including an enlarged liver palpatia, scleral icterus, and also alcoholic hepatitis. The patient's obtunded mental status is also associated with disordered breathing, um, tachypnea, respiratory distress, and hypoxia. Initial management of this patient should include airway protection, including endotracheal intubation, to support the patient ventilation and all that. It's not hemodialysis is typically not used in treatment of alcohol intoxication, as the liver is usually able to metabolize alcohol. Dialysis may be helpful in patients with ethylene glycol poisoning and metabolic acidosis. Nebulized acetylcysteine therapy is a mucolytic agent that has been used in the treatment of asthma, emphysema, bronchitis, cystic fibrosis, and diseases that may be complicated by mucus plugging of the airways. Nebulized acetylcysteine. It will not be indicated in patients as the patient respiratory distress and hypoxia is most likely due to alcohol intoxication. Okay.
Next,
Mm-hmm.
a 15-year-old girl is brought to the physician because of 2 week history of facial rash and fatigue. She has a 9-day history of stiffness and swelling of the fingers. On awake in the morning, she has no history of illness, takes no medication. She appears tired and has mild chest pain with deep inspiration. Temperature is 100.4 degree Fahrenheit, pulse is 94 per minute, regular respirations are 24 per minute, blood pressure is 112 by 76 millimeter of mercury. Examination shows a red rash, bright red rash over the cheeks and nose, diffuse 1 to 2 centimeter lymph node are palpated in the anterior and the posterior cervical chain. There are 3 non-tender ulcers on the soft palate. The lungs are clear to auscultation. Heart sounds are normal. Examination of the extremities show tenderness, mild erythema tenderness and swelling of the proximal interphalangeal and metacarpophalangeal joints, knees, knees and metatarsophalangeal joints. Urinalysis show 2 plus protein and 1 plus blood. Urinalysis show 2 plus protein, 1 plus blood. Which of the following is the most appropriate in determining after appropriate management of this patient?
Mm-hmm. Ready?
1 minute. Okay, it's SLA, isn't it?
Let me see. It's SLE, yeah. Systemic SLE is an autoimmune disorder with a wide range of presentation. In order to make a diagnosis of HLE, four of 11 criteria must be present. These include malar rash, photosensitivity, discoid rash, painless oral ulcers, arthritis, serositis, like pleuritis, pericarditis, neurologic disorder, seizure and psychosis, renal impairment, hematologic abnormalities like hemolytic anemia, leukopenia, lymphopenia, thrombocytopenia, and abnormal ANA assay, or anti-DNA, anti-SMID, antiphospholipid antibody. The patient describes the patient described had numerous of these criteria suggesting SLE. Lupus nephritis is a complication of SLE and is common in younger females. Presents with hematuria and rising creatinine in SLE. Evaluation of lupus nephritis requires renal biopsy in order to accurately determine the type and extent of renal involvement. This information is vital for optimizing treatment nephritis. For example, immunosuppressive therapy is warranted for active diffuse or focal proliferative lupus nephritis, but not mild mesangial or mesangial proliferative lupus nephritis. X-ray of the knees is a commonly used modality to begin evaluating knee pain. However, this patient has numerous other symptoms suggestive of SLA. The arthritis of SLA is non-erosive and non-deforming. It is typically treated with NSAIDs, anti-malaria, or steroid. Because of this, not only would X-ray of the knee be normal, but they would not change the management of patients of this patient arthritis. Proteinuria and hematuria are much more concerning of renal biopsy. Okay, next.
Next,
Mm-hmm.
a 3 year. A 3-year-old girl is brought to the physician because of 2 week history of cough and nasal congestion. Her parents say that she has been tired and irritable for 6 months. During this period, she has been sleeping excessively during the day and snoring loudly. Her pulse is 126 per minute, respiration 36 per minute. Blood pressure is 120 by 86 millimeter of mercury. Uh, on examination, she has nasal congestion and breathes predominantly through the mouth. A grade 1 by 6 hollow systolic murmur is in the fourth left parasternal space. There is tonsillar and adenoid hypertrophy extra of the chest show cardiomegaly. Examinations show right ventricular hypertrophy, pulmonary hypertension, mild TR. Which of the following is the long-term management? Ready?
Mm-hmm. So it's adenoid tonsillectomy. OSA is common in the pediatric population and is characterized by excessive daytime sleeping and snoring. Risk factors for OSA, pediatric OSA include adenotonsillar hypertrophy and obesity. Both lead to decreased airway size and increased risk for airway obstruction during sleep, which in turn leads to pulmonary hypertension. In this case, X-ray and echo findings indicate the presence of cord pulmonale or right ventricular dysfunction caused by a primary disorder of the pulmonary system. Other complications of untreated OSA include systemic hypertension, left ventricular dysfunction, failure to thrive, and behavioral problems. This patient also demonstrates adenoid and tonsillar hypertrophy. Examination in children with this finding, the first line treatment of OSA is adenoidectomy and tonsillectomy. In some cases, watchful waiting is appropriate, but only if OSA is mild and there are no signs of complication. As this patient shows significant cardiovascular complications secondary to OSA, surgical removal of the adenoids and tonsils is necessary.
Next.
Okay.
A previously healthy 10-year-old girl is brought to the physician because of rash over her eyelid and fingers for 1 week. Examination shows okay, sorry. Examination show examination show fallacious erythema of the upper eyelid and erythematous atrophy scaly lesion in the knuckle dorsal surface of the finger joints. There is weakness of the proximal extremities and trunk. Which of the following is the most likely diagnosis? Okay.
Okay. So it is dermatomyositis. Dermatomyositis, autoimmune connective tissue disease affecting the skin and proximal muscles. Cutaneous manifestation include pink papules over the dorsal fingers, the gutrum papules, um, pink to light purple patches over the upper eyelid, heliotrope sign, light pink to lilac color patches with telangiectasia on the upper back and some exposed chest, and dilated capillaries with dropout on the proximal nerve folds. Okay. Juvenile dermatomyositis also commonly demonstrates calcinosis cutis, a deposition of calcium in the skin, An inflammatory infiltrate of the muscle occurs, um, causing damage to the myocytes, leading to release of CK and intracellular molecule. This can be used to monitor disease progress in dermatomyositis. Dermatomyositis is also characterized by several antibodies. It demonstrates a positive antinuclear antibody and anti-Jo1. Anti-SRP and anti-MY2 antibodies are also commonly seen. Dermatomyositis is less likely to be associated with malignancy in children than it is in adults. Treatment involves systemic steroids followed by long-term immunosuppressive therapy with medications such as methotrexate and azathioprine. Next.
An 8-year-old boy is brought to the physician because of 2 week history of rash, 1 week history of low-grade fever, mild headache. The rash begins small red bump on the right thigh, now measures 12 centimeter. His temperature is 100. Examination show no other abnormality except for a rash. Which of the following is the most likely diagnosis?
I don't know. One week history of
She has a fever too.
fever. Don't know. Is it cellulitis? She has fever. Cellulitis. I don't know.
It
Ready?
can
Mhm.
can it be folliculitis?
Yeah, I can also be folliculitis. Oh, folliculitis, it come with fever. I guess, yeah.
Yes, like carbuncle
Yeah.
folliculitis. Small red bump. Okay, let's
Ready?
see.
So is Lyme disease. Lyme disease is a tick-borne disease because I remember because remember we ended up Googling, we were like, where is the clear? We had a question yesterday. I was like, where is the clear center or whatever, clearing of whatever? And then we Googled the image and it was, yeah.
It's not
Lyme
look like target lesion.
it does not. Remember, we Googled yesterday. We were like, "This does not look like a target lead." That's exactly how I remember. We were like, "It really doesn't look like a target lesion."
And even if they haven't give any traveling history.
Any history, yeah. So it's just based on basically, if you see clearing in the center, even if there's not the target thing, whatever, just yeah, think of Lyme disease just by the clearing. Lyme disease is a tick-borne disease caused by Borrelia endemic to northeast United States. In its early stages, it causes erythema migrans, which is an expanding rash with central ring-like clearing. It can also be associated with flu-like illness. In the early stage of Lyme disease, it can be treated with doxycycline, which acts by preventing adverse effects of tetracycline antibiotics include GI distress, photosensitivity, and in children, discoloration of the teeth and inhibition of growth, which makes it contraindicated in pregnancy. Later stages of Lyme disease characterized by carditis, AV block, facial nerve palsy, bilateral, like Bell's palsy, migratory arthritis, arthralgias, and encephalopathy and chronic arthritis. Later stages that affect the heart and nervous system are treated with safety action. It is not cellulitis,
Okay,
folliculitis.
in pregnancy, what we will give in case of Lyme disease?
Was it amoxicillin or ampicillin, something like that?
I don't
Well,
remember specifically.
wait, let me wait. I wrote it. I wrote the notes. I wrote it on my notes. I'll tell you right now. Where is it? Antibiotics right here. Okay, pneumonia, Lyme disease treatment. Less than 8-year-old amoxicillin, more than 8-year-old doxycycline, like pregnant woman amoxicillin, meningitis, chest pain, myocarditis, ceftriaxone. Yeah,
Thank you for the notes.
yeah.
You have read all everything,
What do you mean?
like what you have sent.
Oh,
May
oh, no, 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 no. I was reading like Reddit comments yesterday, and then some girl was like, I don't know why I was reading it. I think yeah, that was I was trying to figure out last oh I googled like CMS versus UR for the last few weeks, whatever, and people were giving their opinions and stuff, and then some girls say just do the CMS, and then there is a the Divine PDF, and I was like, I've never heard that. I heard about the videos, and she was like, no, Divine made like a PDF just for important things of step two. So I texted that girl on the side, and I was like, can you send me that PDF? I've never seen it, and that's when she just sent it to me right now.
okay.
Um, yeah. What else? Oh, it's not cellulitis, folliculitis, and impetigo, or as superficial bacterial infections of the skin. Cellulitis present with warm red patch or black. Folliculitis with follicle-centric pustules on air-bearing surfaces. And impetigo with honey-crusted, typically around the mouth or nose. An expanding targetoid erythematous patch is not characteristic of this infection. So cellulitis is warm red patch of black. Folliculitis, you'll see hair around. Okay.
So I lost. Like in pregnancy, which drug is given in case of Lyme disease?
Oh, let me see. Let me open it again. Amoxicillin.
Okay.
So if the kid is less than 8 year old, amoxicillin. If it's to a pregnant woman, amoxicillin. Now more than 8 year old, that's when you start with the doxycycline.
Okay.
Um, I'm reading like the Reddit I guess the scores came out today, and I'm
Okay.
reading like everybody's like, did anybody got a super bad score like me and stuff? And people are like, yeah, it's really bad, basically.
Maybe question pattern has changed.
They probably change, yeah, because everybody's like, I
But
was scoring 250s on the MBMAs, and now I got a 230 something. And like somebody's like, it's not even like I scored bad, like really, really bad. Like I cannot even say my score is that bad. Like, does anybody feel the same way? So I'm like reading the comments, and I was like, oh my god, this is
it makes me scary.
yeah, it's like it's scary. I'm guessing the results came out. They probably change. Yeah, they probably are changing the.
They probably changed the question
Yeah, they
pool.
probably are. Yeah, the pool. And everybody, all of the people that are commenting took it on the same at the same time, like May 27, May 28, because they are all putting their okay when they took it. And somebody came and commented that have you noticed that you all took it around the same time, May, end of May? So yeah. Anyway,
Oh,
yeah.
this is life. Okay.
Or maybe it's just that maybe we're gonna see, but because maybe it's just that day.
Don't think that the 4 and 5 people do bad. Plenty of people do bad, and 4 and 5 people has the guts to write on the Reddit. You got my point.
Because I've seen people like the people that took
The
it now.
people who are very regular in their posting, who are the people who are very regular in their preparation, they actually post in the Reddit or in the other group. And plenty of people who are the middle, they actually don't uh, go for such posting. Okay, that's my uh, that's my way of thinking. Maybe other thinking is
But there is a
present.
lot of there are the people that have taken it in June. You see the posts that are scoring well. So I think it maybe just had been that day in May, like May 27, where everybody.
As far I know, that in the middle of the Here, they actually change whole question pool.
Yeah, I heard that too. But like if you look at the June results, like the
If
scoring,
you, yes,
it's good. It's good. Mhm.
maybe they got the last part
The last, I don't know, but
because, like, why this thing actually happened. There are USMLE recalls and plenty of inside group where they discuss the question. So,
mm-hmm,
and they
mm-hmm,
actually sell the question also. So that's
mm-hmm.
why the interviewer actually know that there is something fishy, and that's why they actually change the question pool now and then. I think that it was not done previously, but the nowadays it is changing. And there is another, like, you have AI support, so you need not to do uh, plenty of things. You just give your question and keep get a different format. And the people who actually come with that, like, there are some peoples from the Nepals and the other countries,
Mm-hmm.
they actually cram the question that this is the question, so this would be the answer. You got my point.
Yeah,
I have seen the recall also. So in the recall, they actually put 1 to 2 line, whatever they remember, and they give the answer.
jeez.
So like, you can pick some of the question right, but there is a possibility of getting most of the question wrong. Okay, leave
Jeez.
it.
Oh, okay.
We are far away from this.
We are not that far, but okay, I guess there is no point in, Oh.
Life is a race.
Yeah,
Okay.
you don't know. Maybe we'll just fall on the easy forms. You never know.
Yes, all the good hopes. Okay. A previously healthy 6-year-old girl is brought to the emergency department because of severe abdominal pain, nausea, and vomiting that began 4 hours after attending a friend's birthday party. Cake and other pastries were served at the party. She appears acutely ill and mildly dehydrated. Her temperature is 37 degrees Celsius. Pulse is 104 per minute. Respiration is 20 per minute. Blood pressure is 96 by 60 millimeter of mercury. Examination shows no abnormalities of the skin. Bowel sounds are hyperactive. Which of the following is the most likely causal organism?
Oh, Jesus. That's not what I'm trying to get. Next. Oh, ready? Sorry. I'm like next.
Wait 1 minute. Okay.
Okay, so it is Staph aureus. Staph aureus, gram-positive organism that is common cause of cutaneous infections, such as impetigo, cellulitis, folliculitis, furonculosis. Staph is associated with secretion of several exotoxins, including enterotoxin, sphodietoxin, and toxic shock syndrome toxin. Its enterotoxin commonly cause vomiting, diarrhea, and intestinal cramping after ingestion of food contaminated by Staph aureus. Staph aureus enterotoxin is heat stable and occasional and associated with the consumption of foods that are contaminated. Often cream-based foods, food that are left at room temperature, allow staph to multiply and produce more enterotoxin. Ingestion of staph enterotoxin leads to nausea, vomiting, abdominal cramping that typically occurs within like 6 hours. It's not, what was that? Salmonella. What is the salmonella? Classically presents with mucosal inflammation and invasion, non-typhoidal, leading to a toxic appearance and bloody diarrhea. This patient is presenting with vomiting and abdominal cramping, not bloody diarrhea, making this. So Salmonella enteritis causes bloody diarrhea. And Salmonella typhi causes Salmonella. So the enteritis causes bloody diarrhea and the typhi causes the normal diarrhea. Okay. Next.
Next, a 1-month-old girl is brought to the physician because of one day history of decreased oral intake. Her mother says that the child has also had a blood in her saliva. She was born at term following an uncomplicated pregnancy and delivery. Examination showing inflammation and erythema of the oral cavity with diffuse white plaque in that diffuse white plaques that bleed when scraped. Diffuse white plaque that bleed when scraped. There is papillary erythematous rash and satellite lesion over the diaper area. Which of the following is the most likely immune mechanism for this finding?
Mm,
Is it Candida?
Looks like candida, but what is that? With the most immune mechanism? Is it like antibodies? I don't think candida has antibodies. Oh, is the low immunity that causes candida. But is it the B lymphocyte? Candida is fungus, so it must be T lymphocyte. Okay, ready? Yeah.
Okay.
Okay. So decreased T lymphocyte activity. So B for bacteria, T for
Viral
virus.
and fungus.
Okay. Decreased T lymphocyte activity is the most likely cause of the patient white bleeding oral lesions and papular erythematous rash in the diaper area with satellite lesions, which are both consistent with candida. There are many species. Okay. Candida albicans tends to be the most implicated organism in mucocutaneous infections. Candida is a dimorphic fungus that causes variety of infection in both immunocompetent and immunocompromised patients, including mucocutaneous infections and invasive bloodstream infections or UTI. It can phenotypically switch from yes to IFA based on temperature. T lymphocytes play an important role in preventing fungal infections. So, a deficiency of T lymphocyte predisposes to fungal infection. Fungal elements are recognized by antigen presenting cell through interaction with selected receptors. Interactions between antigen presenting cells and CD8 T lymphocytes activate these cells for direct toxicity killing. They also induce them to release IL-17, which promotes T helper 17 cell proliferation. These cells produce IL-17 and IL-22, which attract neutrophils, which are also fungicidal. Okay. Additional cytokines released during this also induce development of Th1 cells, which have been shown to play a role in fungal immunity. So why is it not C? Decreased segmental neutrophil is seen in a variety of disorders having good effects in neutrophil chemotaxis and function. Patients present with recurrent bacterial infections increase segmental neutrophil function. Okay, got it. Next.
Yes. A 14-year-old girl, the 14-year, I have finding problem in gender.
Oh my God.
Initially, I fall asleep in the beginning of our study today. That I don't know what happened to me. Okay,
Oh,
a 14-year, I think that I have OSA. I need to find it out.
oh Lord.
I am obese, very obese.
Do you snore? Somebody told you you snore?
As I don't have any wife, so nobody
Oh my
knows I can
God.
snore. I am so, but I fall asleep while sitting, while even while watching something. Okay,
Oh.
so when I am inactive, like even like inactivity also, I sometimes fall asleep. This is a very concerning thing. Okay, so that's why I don't like to. I never wish to drive. I never wish to ride bicycle.
Oh Lord.
So I actually don't do anything apart from studying.
I'm
Okay,
studying.
very bad, very bad life. Okay, a 14-year-old boy is brought to the physician because his parents are concerned that he has had several episodes of tripping and in coordination over the past 10 months. He has high arched feet and hamartosis. His father has a high arched feet and a history of distal extremity weakness. His mother has type 2 diabetes mellitus, severe diabetic neuropathy. Examination of the patient shows mild weakness of the hand musculature and weakness and wasting of the anterior tibial and intrinsic foot muscle. Deep tendon reflexes are absent and the ankle and decrease elsewhere. Sensation to vibration and proprioception are mildly decreased over the distal lower extremity. Motor nerve conduction velocity are markedly decreased with prolonged distal motor latencies in the extremity. Which of the following is the most likely cause of this patient's weakness?
Hmm, I don't know already.
Okay,
So it is Charcot-Marie-Tooth disease. Um, this was a bad CMS for me. Charcot-Marie-Tooth disease is a heritable disease of peripheral neuropathy as a result of primarily autosomal dominant mutations in gene expressed in the Schwann cells and the myelinating cells of the peripheral nervous system. Peripheral sensory and motor nerves become progressively demyelinated. Patients demonstrate motor weakness and decreased sensation to vibration and proprioception, most prominent in the distal lower extremities. Physical exam findings include hyporeflexia or areflexia, along with clumsy walking and consequent MSK deformities such as pes cavus, high arch of the foot, and hammer toes. Later in the disease course, atrophy of the lower extremity muscles and intrinsic hand muscles, um, and intrinsic hand muscle weakness and atrophy may occur. Diagnosis occurred via nerve conduction studies, which may show decreased conduction velocities and prolonged distal motor latencies consistent with the myelinating disease. Treatment is supported and includes physical therapy. It's not chronic. Inflammatory demyelinating polyneuropathy is an acquired immune-mediated disease of the peripheral nerve roots that leads to symmetric proximal and distal motor weakness and decreased sensation to vibration and proprioception. The cause may be relapsing, remitting, or progressive. In this patient with family history suggestive of peripheral neuropathy, Charcot-Marie-Tooth is more thing. And it's not the kin muscle. I know it's not that one. Facioscapular humeral muscular dystrophy, inherited muscular dystrophy, resulting in slowly progressive asymmetric muscle weakness in the face, scapular, upper arm, lower leg, and abdominal muscles. Sensory neuropathy would be as atypical. Okay,
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 we are
we,
done.
we are done. Unless you want to do the biostats right now, or you want
Okay,
to leave it for tomorrow.
okay, I'll just leave it